evening, everyone. Welcome to our Leadership Forum. I'm really delighted this morning to welcome Dr. Charles Sorenson as our guest, and his wife, Sherry, who's sitting on the front row here with us. Dr. Sorenson is a urologist, trained at Cornell Medical Center in New York City, and has been here in Salt Lake City since about 1982. He was in clinical practice for many years, and then became involved with Intermountain Medical Group as their head in integrating doctors and clinicians into the IHC system, and then became the executive vice president of IHC and chief operating officer for over a decade, and has then served as the chief executive officer and president of IHC for almost a decade. He stepped down last fall from that role and has taken on a new assignment as head of the IHC Leadership Institute, which will be unique in the world, actually. And the way I conceive of it, and Charles, perhaps you can correct my thinking on this, is it will be something like the Harvard Business School for medical people. Leadership lessons and leadership insights for running complicated healthcare delivery systems. That program will be kicked off next fall, I think, is something
Correct.
Like that. So please join me in welcoming Dr. Charles Sorenson here to the Huntsman School. So Charles, let me just visit with you a little bit about your career and the influences that you've had as both as a doctor and as a leader. But before I do that, let me just acknowledge that you're wearing a green tie. It is St. Patrick's Day, and you're from Sweden.
I know. I don't think you can have lived in New York without recognizing when St. Patrick's Day arrives. In fact, I actually picked out a tie last night. I was going to wear a dark blue tie, to be patriotic for the place that I'm speaking today. We are. And then I remembered that it was St. Patrick's Day, and I thought, okay, well, I got to go with it.
Well, it's entirely appropriate. I think we're all Irish for at least one day.
Yeah, that's right.
The other significance of this particular day is that it's the 1 year anniversary, actually 1 year plus 1 day anniversary, since we opened up Huntsman Hall. In fact, a year ago yesterday, in this room, we had the governor and many other notable people, and John Huntsman, of course, and Karen Huntsman, celebrating the opening of Huntsman Hall, which is an incredible facility for us, and we're delighted that you could be here and join us. Charles, I know that you like to say that you're the only member of your family that couldn't get into Utah State University, but let's just sort of unpack that a little bit. Your father graduated from Utah State and then went to Harvard Medical School?
Started before then.
Yeah.
My great-grandfather, Charles Sorenson, immigrated here from Denmark and settled in Hiram. My grandfather, Charles Sorenson, grew up there and then went to college here and became a professor in the Department of Biology. Okay. And so my dad and his brother grew up here. Both my dad and my uncle graduated from the college here. My dad went off to medical school, and then my only sibling, my brother, went to undergraduate here. All my cousins went to undergraduate here, and I'm the lone errant in the family who went to a place in Salt Lake. But Utah State and Logan have lots of great memories for me. My dad loved it here. Sherry's parents both graduated from here. Sherry and I met in New York, interestingly enough, but lots of deep roots here, great memories of when I was a kid in the middle part of the last century. We'd come up here, my cousins and I, and spend a week with my grandfather and grandmother who lived on 5th North, just below Old Main Hill there.
Oh, yeah. Well, you've got Utah State DNA, and so we're delighted to bring you back to your home territory.
I always feel this is home when I come up here.
Absolutely.
Get up here a little bit over the years because we have this great hospital up here. Thanks for Kyle, who's our CEO of our Logan Hospital, for being here this morning. So it's always a pleasure to be in Logan.
I want to just ask you something about hospitals in Utah. Maybe we start there. We're reading in the newspapers every now and then that there's a doctor shortage in Utah. Is that really correct?
Yeah, that's a great question. Utah has fewer doctors per capita than most states. Is there a doctor shortage? We don't really think so. There's a maldistribution of physicians. In other words, it's hard to get doctors to move to really small rural communities.
Would you include Cache Valley in that?
No. I mean, this is such an attractive place for people to live. I mean, it's a great college town, beautiful environment, and there's a really capable hospital here. There's a couple hospitals here, and so no. I mean, but I'm talking about going to places like Delta and Fillmore, and those little places in eastern Utah and parts of Idaho as well. But actually, I mean, for instance, the last I looked at it, Utah has more plastic surgeons per capita and orthopedic surgeons than most places in the United States.
Yeah, I'm not sure what that really means, but
yeah, well, I kind of have an idea, but it's so it's really a maldistribution. The other thing is, I think you really ought to measure the number of physicians per capita, not just based on numbers of doctors, but are the doctors busy, and are they, most importantly, I mean, we ought to measure all these things by what the outcomes are, and Utah has among the very best, the top 3 or so, health measures in the country overall. And one of the interesting things, the way it works, and there's reasons for this that we could get into if we had a time to talk about it, but in healthcare, increasing supply does not reduce costs. It increases costs. So places where there are the highest number of physicians per capita, like Florida, have the highest healthcare costs per capita, but actually they have poor overall health outcomes. So it's the usual supply and demand, the way economics work in healthcare. Having more doctors does not reduce healthcare costs.
well, this is a college of economics as well as business, so it is important for us to drill down on this just a little bit. Why do you suppose Utah, you don't need to suppose because I know you know, why does Utah have such good healthcare outcomes?
Yeah, well, thanks for asking. I mean, I think we have, it's one of the things that attracted me back to Utah. I got on a plane after I graduated from, I had always wanted to go to medical school on the East Coast, and ended up deciding to go to Cornell, which is in New York City, the medical school. And it's at the New York Hospital there where it's a fabulous place. It's arguably the most capable quaternary hospital in New York City, and was then. And I loved it there, I really did. But while I was there, I came back one summer to do an elective at LDS Hospital, which was 3 blocks from where I grew up. And where I had worked for a guy named Homer Warner, who was a physician, computer scientist while I was in college. But I always kind of thought it was my hometown. But I wanted to come home for the summer, and so I arranged an elective in cardiac surgery with Russell Nelson, who was one of the best known cardiac surgeons in the country at that time. And LDS Hospital was one of the busiest cardiac surgery services in the country. And I'd spent 12 weeks on the cardiac surgery service at the New York Hospital before I came out here. And I got to tell you, Doug, I was pretty astounded at what was going on in my own little hometown hospital. There was just no comparison in the outcomes, in the professionalism of the staff, and the willingness to do the right thing for the patient. I mean,
even in contrast to Cornell's great center in New York?
Absolutely.
Wow.
Absolutely. And I mean, I was just kind of dumbfounded by that. It was this attitude of, yeah, we can get this done. I mean, if you as a medical student, one of my jobs at Cornell was to gather the x-rays up for afternoon rounds. And so I was told by people in the class ahead of me, one of the ways to kind of do that is you'd bring a nice bottle of Johnny Walker and give it to the guy who ran the x-ray file room, because then he'd be sure that your team's x-rays were all pulled out before. And if you wanted to get some imaging study done in the night, it was kind of hard to get the staff to come in. I mean, at this great big hospital, and here it was like, yeah, we'll be right there and get it done. I mean, it was astounding. And it started me thinking about a different way of health. So I think, long answer, excuse me, of your question, what's different here? I think there's always been this attitude of, yeah, we want to do the right thing for the patients. Not that we're perfect out here, but it's just part of the ethic of these communities, and I think that's it. The other thing that we've been fortunate, I mentioned Homer Warner, who did his training in cardiology and in physiology, and he did that back at Minnesota and then came out to LDS Hospital. And a brilliant guy, he got interested in using the computers in medicine very early. In the late 50s, he got the first computer that was used in analyzing cardiac waveforms. It was an analog computer. Got a picture of him within this thing. It looks like an old-fashioned telephone switchboard with all these plugs and wires that you plug in and dials to turn. He got, by the time I worked for him when I was in college for 3 years as a computer programmer, he had an impressive digital computer that took a very large room, almost the size of this, on the top floor at LDS Hospital, which of course had less computing power than your iPhone has now, but it was impressive then. And he was the first person to, around here, there were a couple other people, including Octo Barnett at the Massachusetts General Hospital in Boston, but who were using computers for data analysis. And he gave us this remarkable legacy at Intermountain of tracking outcomes. And, you know, as Jim Collins says in his book, you know, you can never improve unless you confront the brutal facts. And what we've found in healthcare is that whenever you objectively measure what you're doing, you always find out that you're not as good as you thought you were. But it gives you a tool to improve. I think that was the focus. The other thing that was remarkable about Utah was the gift from the LDS Church to the community that it made in 1975 when it divested itself of its 11 hospitals, and instead of selling them to a for-profit company, they created Intermountain Healthcare, a not-for-profit organization, totally independent from the church, and gave them to charge to become a model health system. And the board from the first said, our focus is excellence in healthcare services and doing that affordably. I don't know any place else in the country, and I was around in 1975 taking care of patients. I don't know any place else that was focused on the cost of healthcare the way that Intermountain was down there, making it affordable to people. The attitude was, yeah, healthcare is expensive and it's getting more expensive, but that's what people demand, and they'll just have to figure out a way to pay for it. So I think those are some of the early reasons.
Well,
and finally, let me just say, I'm going on too long, but
not at all.
The other thing that's made a big difference here is I give credit to the University of Utah, which has had an outstanding medical school and especially residency training programs that we've participated at Intermountain with all these years that provide our state with high quality doctors. About half the doctors who work here trained here as residents.
Well, those are all great reasons, and they cite to the fact that you as CEO were building off of a great foundation. And yet in the 2012 presidential campaign, both Mitt Romney and Barack Obama cited Intermountain Healthcare along with Cleveland Clinic as the two places in the country that we ought to look to if we're going to resolve the problems we face in healthcare. And they would not have done that if they were just referencing what happened between 1975 and 1985. So bring us up to date on what you guys have been doing, what you've been doing. I don't mean to put you on the spot, but you have been a great leader of this country's most important healthcare system during a period of time when we've had a huge crisis in this country about healthcare. What have you been doing differently?
Well, first, my greatest talent is being smart enough to affiliate with people who are way smarter than I am. And be part of an organization that really is dedicated to a noble mission. We changed our mission statement actually 3 years ago. Our mission statement from 1975 was excellence in the provision of healthcare services. And one morning I was kind of thinking about that, and I thought, well, I wonder how many people are waking up early in the morning and thinking, oh, I hope this is the day I get really great treatment for a stroke or great surgery for an aortic dissection or something like that. Nobody thinks that. I mean, if you're lying on the gurney outside the OR, that's what you want. But what do we think in the morning? We think, gee, I hope that the people I love have good health today. And I hope I have good health. And so we changed our mission statement to helping people live the healthiest lives possible. And it really kind of gets us upstream. It's really what we've been working on for a long time at Intermountain.
You went from input to output.
Yeah,
with that statement.
And really kind of thinking, what Clayton Christensen, who's, written this book, his most recent one, Competing Against Luck, is, what does the customer really want?
And who happens to be on your board.
Yeah, he's been fabulous.
Yeah.
But really thinking, okay, well, is that what people want from a health system? Do they really want us to they want us to take care of problems as well as anybody in the world when they're there, but really they don't want those problems. And so, getting to the answer to your question, what we've worked on for a long time at Intermountain Healthcare for 30 years is bringing the components of healthcare together in an integrated way. Not just the hospitals looking for more volume to do more stuff to charge more money, but having a health plan that provides, that covers about 28% of the patients or so, Kyle, something like that, of the patients that we care for at Intermountain, but not all of them. But is sensitive about the cost, and the physician group, as well as the independent physicians, who want best outcomes for patients, and then trying to align incentives so that we're rewarded when, if care is needed, we provide it as effectively, as efficiently as possible, and we eliminate the many things in healthcare that add only cost and risk to our patients without benefiting outcomes. And we've been willing to do that even when it detracts from Intermountain's bottom line. So that's been our effort, and I think we've been able to demonstrate, clearly not perfection, but we've been able to demonstrate as a pretty large system that those techniques of consistent application of evidence-based best practices and a focus on keeping people healthy results in better outcomes at lower overall cost to a community.
All the way up to the point where you said, even when it has a negative impact to the bottom line, I sat here thinking, you're sounding an awful lot like a businessman.
Yeah, well, we've had to do that, because it's the right thing to do. An example of that, Doug, is 3 years ago, Dr. Don LePay, who's an outstanding cardiologist who leads our clinical program in cardiovascular services, got together with our cardiologists, all of whom work in our hospitals in Salt Lake Valley, are employed by Intermountain. I said, let's take an updated, fresh look at best practice guidelines on the 4 things that cardiologists do most commonly. And that included nuclear stress testing, placement of a stent, implantation of a pacemaker, and implantation of an automatic defibrillator. And they looked at the indications, the latest scientific literature, and they said, okay, we are going to impose upon ourselves a checklist of when we're going to do these things, and we're going to discipline ourselves. This didn't come from the health plan or anybody else. We're going to only do these things if they meet these specific indications. And the indications were significantly more rigorous than typically practiced out in the community around the country. So what happened after a year, they reduced those procedures that reduced the bottom line of the Intermountain Medical Center by some $14 million a year. At least stable clinical outcomes, may be better because we didn't do unnecessary things to people that might have led to other complications. So lower costs and better outcomes. And for the cardiologists at the time, some decrease in their income as well. So I talked to the cardiologist and said, well, this is really impressive what you've done here. Better outcomes, lower costs to the community, lower revenues to Intermountain Healthcare, but also, you guys have made less money. How do you feel about this? And it was really interesting, their response. I talked to about 3 of them individually. They said, yeah, we made a little bit less money, but you know what? It's the right thing for our patients. And it's the right thing economically too. Doctors, it's been our principle all along that if doctors really feel like we're making changes because we're interested in best clinical outcomes for the patients and we're interested in affordability in healthcare, they get engaged, even when it goes against their own economic interests.
Yeah. You've already cited 2 great management thinkers, Jim Collins and Clayton Christensen. Another is a guy by the name of Katzenbach who wrote a book called Pride Matters More Than Money. And what you've just described is a group of professionals who care more about the noble purpose that they're serving than their own short-term pocketbook after a certain level.
I absolutely agree with that, and I could give you a number of examples right now in other specialties when that's true. That said, I have to say that you can't just continue to do that forever, because there's one of the problems in healthcare in America is we do too many things to people just because it produces revenue. And and we kind of think of adding new technologies or doing tests or procedures because patients kind of demand it and because it brings us revenue. And it's to the point where consistently academic people who look at healthcare say that somewhere between 30 and 40% of all the procedures and tests that are done to patients in the United States are unnecessary. That's shocking. Can you imagine if we didn't do that? That solves all the healthcare cost problem in this country. And so we've been working on that through our clinical programs on eliminating those things. But you can't continue to do that forever and have radiologists who say, you really don't need to have an MRI scan given your clinical scenario. You don't need to have a CT scan, or a orthopedic surgeon who says, you don't need to have your knee replaced. You could do these exercises. If then they get disadvantaged economically. So what we're working on now, Doug, is aligning incentives for doctors so that they do well for their decision making, not just for doing more things that add cost, and that's really important.
One of the great brains that works along with you that you say that you really depend upon is a guy by the name of Brent James.
Yeah.
And Brent was featured on the cover of New York Magazine some years ago with the headline, "If America wants to solve its healthcare problem, they'll listen to this man."
Yeah.
What's he done for IHC?
So Brent James is a great guy and a good friend. He went to medical school, and then he did a few years of residency in general surgery, and then he got a master's of statistics and was working back in Boston with the Harvard hospitals on the cancer programs back there, and had really become interested on using data to track outcomes. And in the late 1980s, in a great move, Scott Parker, who was then the CEO of Intermountain, got to know Brent and invited him to come back to Intermountain. And Brent set up really the first system quality improvement program at Intermountain in the country, based on the principles that were established in manufacturing by W. Edwards Deming, whose thesis is that your students probably know, among the things he thought, is if you improve quality and eliminate waste, you get a better product at lower overall cost. Mm-hmm. And so Brent came back, and the reason he came here, he was there at Harvard, the reason he came here is because he found an unparalleled richness in the data systems that had been established by Homer Warner over the 15 years before then, and started tracking things. One of the very first studies that we did, actually did this before Brent came, was looking at the outcomes for some of the surgeries that we did in our department of urology at LDS Hospital, and showing those to the doctors. Here's the difference in outcomes for your patients with this given procedure. Here's the variation in length of stay, variation in blood usage, variation in lab use and the time in the OR. And they just came to us and said, hey, well, look at this. And I can remember this day. It was in about 1987, and these guys showed up, one of the finance guys and one of the planning guys said, hey, we've got some data. Can we show this to you? Who are these guys? And they started showing us this stuff, and it was broken out by each of us as individual doctors. And we said, who are these guys, and what do they know about what we do? And it was kind of uncomfortable because you saw yourself where you are on this graph with variation, and some of us looked pretty good, and some of us didn't look so good, and none of us looked good on every chart. And then they did a great thing. They said, well, we're not experts. You're experts in when you should operate on these patients and how you should do it, but we just see a lot of variation, and where there's variation, there's opportunity. And you got to talk to each other and see how you can get better. And then they left, and we kind of looked at each other and said, what's that? And some of us were kind of irritated, like it's none of their business. But then we went through all those stages that Kubler-Ross describes of dying, of
the grief
of
cycle.
Anger and
shock, anger,
and
denial,
exactly, bargaining, exactly. We did all that. And it finally got to acceptance, and people started saying, "Hey, can I come by the operating room and see what you're doing? Or can you really, take out the tubes after 2 days instead of 5 days or whatever?" And a year later, the whole bell curve for everybody had shifted to the good, and that was the principle that Brent used, and then started doing some studies, and then by 1997 we said, Brent, don't just do this on individual things. We got to do this in a systematic way at Intermountain Healthcare. So we set up what we call our clinical programs in 10 different areas of clinical endeavor, starting with cardiac services and women's and newborn services, and using evidence-based best practices, measuring outcomes. I don't want to say that we're perfect by any means, because we're not. But we've made a lot of progress by just objectively confronting the data and saying, how can we get better?
One of the principles of Deming and Duran and Shingo, who invented the Toyota production system, and whose prize is given here by the Huntsman School every year, was that you can always get better, no matter how good you are. It's a never-ending journey of improvement. And is that part of the idea behind the establishment of this new leadership institute that you're involved in? And is Brent going to be involved in that with you?
Yeah, Brent has, it's a very important part of what we're talking about, the Leadership Institute. So Brent has been running a course at Intermountain called the ATP, the Advanced Training Program in Clinical Quality. And he's been doing that for about 22 years or something like that. And people come from literally all over the world to do that. The course runs for 3-week segments about 3 times a year, and there's a waiting list of about 2 years to get in. So very popular, and people from great health systems come, and we learn a lot from the people who come from elsewhere. And so it was about 7 years ago, and I meet a couple times a year with CEOs of about 30 other health systems that I've gotten to know really well, and talking about these things. So many of my colleagues who were non-physician CEOs of health systems said to me, Charles, where are we going to find physicians who understand the needs of healthcare and can become future leaders? There really isn't any place to do that. And I thought, well, that's interesting. And so I actually talked with some friends at the Harvard Business School, Tom DeLong, who you know so well, and a couple others, said, do you know of any place that's doing this? We really want to focus not on trying to replicate an MBA. Mm-hmm. People can get great MBAs here or Harvard or any place, but really focus on this crucial intersection of deep understanding of clinical care processes and administrative excellence. Because there's really no place that's doing that. And you can't do that if you're just an academic place that's not connected with the health system. So started talking to the folks back there, and I said, what do you think if we put together something and maybe have you guys, some of your faculty come and teach some of the business principle stuff and we do the other, and they thought that was great. So that's really the genesis of the Leadership Institute, which is a little different than Brent's course, which is very specifically focused on measuring processes, clinical process improvement. But we'll be there in the same building along with our clinical program team leaders, and kind of located on the Intermountain Medical Center campus, kind of the place that people could come to learn how we're trying to change healthcare at Intermountain.
Great. You've talked about costs and positive outcomes, but one of the big issues in healthcare today, and it has been for a long, long time, is safety. And I don't know if the number still holds, but for many, many years, the shocking number was that there are 100,000 deaths in hospitals in America every year that shouldn't have happened.
Yeah.
Can you speak to that issue a little bit?
Well, absolutely, and the number is shocking. I mean, you know, it's the equivalent of 2 747s crashing a day. And I'll be honest with you, when that came out from the Institute of Medicine in 1999, I think, in this book, To Err is Human, I was Intermountain's chief operating officer, and that was pretty shocking to me because, you know, I said, is this really the right number? I mean, because in my experience of 20 years, more than that, of clinical practice by then, I had never personally seen somebody die of a medical error. Mm-hmm. But the way, and I'm not trying to justify this, but the way the number was calculated also includes the errors of omission in routine management of healthcare situations. If somebody's hypertension wasn't adequately controlled and they had a stroke or a heart attack because of that, that's an avoidable death, a medical error. And those are the things that don't even really surface on the radar screen. As a surgeon, it's very, you know, if somebody dies because you make a medical error, everybody knows about it. I mean, you just, because it's shocking to everybody. If somebody's given a wrong drug and they die, you know, that's shocking. But, you know, whether the number was a little higher or a little lower, I don't know, but it clearly was a wake-up call for all of us in healthcare in the United States about, and our focus on how to improve that really has been very much the same way that we were focusing on clinical excellence that I talked to you about before, following evidence-based best practices. And as some great writers like Atul Gawande, by the way, if you ever want to read a great writer, pick up the New Yorker and read some of Atul Gawande's articles on healthcare or his books. And he wrote this book called The Checklist, which, you know, it's like pilots when they get on the airplane. What do you see them doing up there? They're going through, okay, we've got all these things, all these switches are in the right position, we've checked this and this and this. Well, wow, 20 years ago, when we started trying to get, when this all came out, we started trying to get doctors to do a checklist in the operating room, it was like gigantic pushback. And from some of these really strong personality doctors say, well, that's insulting. Why should I have to do a checklist? Of course I do that. And you say, well, look, here's the difference in outcomes in places that are using those consistently. But the thing that really worked the best when I talked to audiences of surgeons, I said, okay, so you're telling me that when you get on an airplane, you'd prefer to be sitting there, and then just before the plane takes off, some guy with his leather coat and his scarf gets on and says, okay, where's the pilot seat? I'm ready to fly. And the co-pilot says, oh, well, sir, don't you want to look over the checklist? He said, pah, I don't need that. I've been flying for 20 years. I know what to do. I fly this thing by instinct. Is that what you want? Do you want to fly with that guy, or do you want to fly with the kind of nerdy guy who's sitting there with a checklist and saying, yes, check, 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 who also has experience doing it? So we got.
When you mentioned Dr. LePay, I thought of Atul Gawande's book, Better.
Yeah.
Great
Fabulous
book.
Yeah.
Fantastic. So is that number coming down?
Yes.
It is.
Yeah, we're measuring it. And, you know, one of the things is we've had at Intermountain Healthcare, tragically, we've had some errors of miscommunication or lack of recognition of early warning signs. And about 6 years ago now, we had a 14-year-old girl die at Primary Children's Hospital, which is an extraordinary place. Mm-hmm. It was because of a poor communication. And it was the only daughter of these wonderful parents. Mm-hmm. And that stimulated the wonderful leadership at Primary Children's Hospital to say she can't have died in vain. And with permission with the parents, they said, we'd like to talk about your daughter's case and dedicate our safety improvement efforts. I guess it's a little longer than that ago that this happened, starting at primary. And I became aware of that then and visited with these parents several times. I said, we want to do this at Intermountain. And we created a video interviewing the parents, interviewing Katie Welke, who's a remarkably wonderful chief executive of Primary Children's Hospital, and Dr. Ed Clark, who's our medical director then. And boy, we showed that to about 18,000 leaders at Intermountain Healthcare. And you can't watch that video without feeling this responsibility that we can't let that happen again. Tragically, we still make errors. We're humans, and I don't know any endeavor like healthcare that is so the process is so dependent on complex decisions made by individuals. So probably there'll always be errors, but we're getting better.
You know, this is a leadership forum, and you've already hit on so many important leadership lessons, but what is it about life and death decisions that you make that focuses the mind, that causes you and everybody else that works in the hospitals to want to get better?
Yeah, I think it's a powerful focus. Maybe some of you have read a book called The Power of Why, or seen a video by a guy named Simon Sinek, S-I-N-E-K. He's got not YouTube, but TED Talk that takes 15 minutes, and it's great. And Sinek said that he studied individuals and organizations that had made a profound impact for other people or for their country. I mean, people like Martin Luther King, or other people like that. And he found something that they had in common. He went and interviewed people in different organizations and found that everybody can tell you what they do at work, and almost everybody can tell you pretty well how they do it. But he said, actually, few people in most places can tell you why they do that every day. And beyond the obvious, well, it's my job and that's how I earn a living. And he said, but the places that make a difference engage people's hearts with a profound why. And so, I saw this years ago and I thought, wow, who's got a more profound why than we do in healthcare? We're dealing with the thing that is arguably the most important to people, the health of the people they love and their own health and lives. And I think communicating that to people, getting them kind of sometimes shocking them out of the routine of, oh yeah, we just go through these processes every day, and reminding ourselves regularly that, wow, why are we doing this? It's for the most profoundly important why there is. It makes these hard and stressful jobs, at least for me, much more meaningful and gives you energy, but it also renews your commitment that you've got to do everything you can to eliminate errors of commission and errors of omission that might result in irreparable harm to people.
Well, it's a wonderful, wonderful response, Charles, and as you well know, Kathy, my wife, and I faced that question very directly at LDS Hospital 4 years ago this May, when she was facing the need for a tandem bone marrow transplant, and you become very, very clear about what matters most in life.
Exactly.
And thanks to Dr. Peterson and the great people in the clinic in the bone marrow transplant there, she's still alive today, and we're very grateful for that.
They're fabulous. And let me just say, for those of you, thinking about your careers, think about that a little bit. I mean, the why of what you do. And healthcare is not the only endeavor that's got a profoundly important why. Education has a profoundly important why. All kinds of community service people, people who are willing to be on the highway patrol. What a hard job, pull up to some car in the middle of the night someplace. Those profoundly important whys will change your life for the better, in addition to being a way to earn a living. I mean, you, Doug, you could still be off in consulting, making way, way more money than you do as the dean of this business school. but you're here. I think I know you well enough because you're motivated by the opportunity to help great folks like these and the others on this university and other places around the country live better lives and make an even better contribution to our society.
Well, it's kind of you to say that, but this is a leadership forum about you, not
Oh.
about me. So I have three quick questions before we open it up to the audience to ask some questions. We've touched on two of the three areas. You've been and are a practicing urologist, very well-trained specialist in your field. You have been a CEO. You've also been a church leader. You've been a stake president in the LDS Church. So here's a couple of quick questions. What did you learn as a urologist that you were able to apply as a CEO?
Well, I think that's a great question. Some of my most profound leadership learning experiences were from other clinical leaders, probably starting in medical school with the chairman of the Department of Surgery at Cornell, a guy named Tom Shires, who was a pretty soft-spoken guy, but had an intense sense of right and wrong. And if I could tell you, do I have time for a really quick
Absolutely.
story? So I'm a medical student, and we're operating with a new attending surgeon there at the New York hospital, who I'll make up the name, Dr. Alsop, who had come from a very prestigious health system up in Boston, and who was famous for an area. And he was doing one of his first cases. So the chief resident's there helping Dr. Alsop, and I'm there. And so, frankly, the operation was struggling, and it wasn't going all that smoothly compared to others that I'd seen, similar. So the guy asks for something that the attending surgeon says, I need a Bazuski retractor, some kind of thing that nobody had ever heard of. And the scrub nurse says, well, I don't have one. She says, what do you mean you don't have one? And she says, well, maybe you could, this is what it is. And he says, well, maybe you could use this, and looked like a good thing for us. And he took that thing and he threw it, just narrowly missing her across, and it went over and hit the green tile on the side of the operating room, and a little crack you could see in it. And boy, everybody kind of went quiet when he started swearing and saying this. What kind of a place have I come to? This is incompetence, but it's just terrible. Here's a patient, open on the table. So I was in a position where I was holding a retractor or using a suction or something. And I could see after a couple of minutes when they were back focusing on the operation, the circulating nurse stepped out for about 1 minute and came back in. 10 minutes later, in comes Dr. Shires, chairman of the department. Says, well, Dr. Alsop, how's it going in here? And he says, oh, really well, Dr. Shires. We're doing this operation. You want to come see this? And Shires kind of walks over and looks down, and he says, well, I hear it's not going well at all. He said, oh, really? No, it's going well. He says, no, I hear that you're throwing instruments and using foul language. Well, I needed this, and they didn't have it, and I got a little carried away. And Shires says, in front of even me, the medical student, he says, let me just be clear. If you ever throw an instrument in this operating room or swear at somebody again, that will be the last day you work at the New York hospital.
Wow.
How fast do you think that got through every place? I mean, that courage to stand up and do the right thing and not tolerate misbehavior was profound. So I had the privilege of working with lots of amazing people, starting with Homer Warner, who was a remarkable person, who gave all the credit to the people with whom he worked, was concerned about individuals, including me as a little undergraduate student writing computer programs for him, and always asking how he could help. Those kind of lessons are invaluable.
Fantastic. Second question, what did you learn as a church leader that you used as a CEO?
Well, I kind of feel like I feel like I was the wrong choice for the CEO job and the church leader job. I think there are a lot of people that would have been way better for both of them. But I've just seen so many dedicated people who it's not about them. Mm-hmm. It's about, quiet service to other people and avoiding personal credit or acknowledgement, actually feeling pained when they receive it. There's a guy in our neighborhood, a guy named Dan Gardner, who owned Dan's Foods, if any of you are from Salt Lake, and founded that in the 1950s. And this guy was unbelievable in our neighborhood, taking care of widows and other people. He'd charter a plane in the winter and take these older women down to Phoenix and have a week vacation getaway. Boy, but you try to thank him for anything and he'd just get irritated with you. So that quiet service, probably the best leadership example I've seen. I wish I could be more like those people.
That's great. And the final question, what did you learn as a CEO that made you a better urologist and a better church leader?
Yeah, all I ever wanted to be, Doug, was a physician and a surgeon. And I never really aspired to any leadership position. Was asked to do it and thought, well, I guess they need a doctor, I guess I could do it. But and sometimes over the years as a CEO, you lie awake at night and worrying about this or that and think, why did I ever do this, brother? I got a lot better sleep when I was on call for the emergency room for a week. But, if I hadn't had those experiences, I never would have learned so many things that I've learned and met people that I've learned so much from. And if you believe life's about learning, which I do, and learning about people and how to improve yourself. I mean, it's been a fabulous experience, and I'm very grateful that I had the opportunity to do it.
Fantastic. So we'll turn now and open it up to questions from the audience. And who's got our first question? If you'd stand and just tell us your name and what's your major, that's great.
So my name is Matt Baker. I'm doing finance and economics, but I want to go into healthcare administration. So my question is more just like, for that career field, what is some advice you would give to a student in my position?
Yeah, well, I think that's great. I mean, with a background in finance and going into healthcare administration, either through an MHA or a combined MBA-MHA program or an MBA program, any of those kind of things. But I think it's really important early on to figure out if that's really what you want to do. And I think educational systems in the United States, I think we can do a better job of helping young people understand what it's like to really do that work every day. So maybe you can find an opportunity to work part-time in a hospital or in part of a health system and kind of get an idea of what it's like. I think that's essential. Where we live in medical school at Cornell, it's on the east side of New York. It's a great neighborhood, and you can't afford to live any place except in student housing, which is across the street from the New York hospital, which was great. But we got to know everybody. There were 100 kids in our class, and I knew every single one of them really well. And I can remember sitting at graduation, and these are very bright kids, good people, hard workers, but I got to know them well. And I can remember looking down through the list and putting a little dot by 15 or 16 names who I knew that if they had known going into it what it was going to be like to be a doctor, they would not have chosen that path. But by that time, so much of their life and effort was invested in it. And that's sad. So find out what it's like to be a hospital administrator. Go talk to some brilliant guy like Kyle, and he can connect you with somebody who can help you understand that, or what it's like to be a dentist or an attorney or something before you pick that. Does that help?
Next question.
My name's Ashley. I'm also a student in economics and finance. And as you were saying, you started your career as a urologist, and you never saw yourself going into these leadership roles like COO and CEO. What do you think, in your opinion, is the pivot point of your career that kind of drove you in that direction, I guess?
Yeah, thanks, Ashley. It's an interesting question. So in the years that, while being CEO, from time to time, I would complain to my therapist and best friend, who's also my wife, about how did I ever get in this job, all this stress and stuff. And I said, I should have just stayed in full-time clinical practice, taking care of patients with urologic cancers. And Sherry would say, well, that was never enough, was it? And I said, huh? She said, well, you're always doing something else. And that's kind of true. I mean, I'd been I'd been the president of the Utah Urologic Association. I'd been the speaker of the House of Delegates for the Medical Association. I'd been the vice chairman of the Department of Surgery at LDS Hospital, and I was the president of the medical staff. And I think what changed my perspective the most was being the medical staff president at LDS Hospital when I was pretty young, and getting involved with Intermountain Healthcare. And then realizing, and this was about 91, or I guess it was 92 when the Clintons got elected, and Hillary Clinton said she was going to change healthcare. And I thought, you know, healthcare is so dysfunctional, and one of the big dysfunctions in healthcare is we've got doctors competing against hospitals and vice versa, and it's not focused on the patients. Wouldn't it be better if we could kind of get the doctors and the hospitals and a health plan or two aligned, similar things? So we started talking with the consultant McKinsey and senior leaders at Intermountain Healthcare about forming a medical group within Intermountain Healthcare. And that's kind of what started changing. I realized that there was something besides taking care of one patient at a time that was important to me. That was probably it. From that, I went on the Intermountain Healthcare Board in '94 and got to meet these amazing people who voluntarily serve incredible hours, and just see that side of things. That really got me hooked. But it was still a hard decision to leave full-time clinical practice when I did that, because I love that. And I'm lucky that I could still spend usually a morning a week in the operating room helping on the bigger cases, which I continue to do to this day.
Well, I'll ask another question while you're all thinking about it.
Got some hard questions for
let's
Doug.
let's remember this is about audience participation. So you mentioned your board, and I happen to know quite a number of members of your board, but one in particular has served as your chairman for many, many years and has been a great community leader, and that's Kim Gardner. Can you talk a little bit about the contributions that Kim Gardner has made to IHC? I think the new institute is going to be held in the Gardner building, is it not?
That's correct. Kim's an extraordinary person. He's larger than life in many ways. So for those of you who don't know, Kim Gardner's a developer in Salt Lake City. He grew up in Star Valley, Wyoming, very humble beginnings, and he's brilliant. So he ended up going to the University of Utah, and then he went to law school. And he says he didn't study very much because he was busy doing a whole bunch of other stuff then, but he kind of read all the books the night before the exam and passed, the bar exam with flying colors. And then he went off to be an assistant to
Senator Moss.
With Senator Moss. What is it, a fellow or something like that?
No, he was at the time they called it administrative assistant, but it's now chief of staff.
Oh, yeah, okay.
Of United States Senate.
I knew it was something better than an intern. He was at a pretty high level.
Yeah.
And he did that until Senator Moss left the Senate, and then was going to go into law practice in Los Angeles when his friend Roger Boyer, who had started this development company, said, "You don't want to go work for a law firm. Come with me and we'll." And I think Roger Boyer and Kim Gardner were kind of a magical combination. Kim was extraordinary people skills, very spontaneous and very bright, and Roger very detail oriented. But Kim has always been a remarkable public servant. He chaired the Airport Authority Board when he was just a young guy in his 30s. When he first came back to Salt Lake, he got involved with the Intermountain Healthcare Board, I think like in '84 or something like that, at the same time that Spence Eccles, who's still on our board, got involved and became our board chair. Kim is very larger than life, and I am very, I'm kind of more reserved and introverted, and so when Kim became the board chair, because the board selects the chair, I thought, well, this is going to be interesting because we're such different personalities. And I really it was a great learning experience. I really came to appreciate Kim's strength, his generosity, his good judgment, and his consistent desire to be supportive of Intermountain Healthcare and doing the right thing. And so Kim served for 5 years as our board chair. We have a term limit of 5 years, and was followed by Scott Anderson, who's the CEO of Zions Bank, who's been our board chair now for 4.5 years.
In
who's
fact,
been extraordinary.
Scott's coming to this leadership forum in 2 weeks.
Oh, well, come. I mean, Scott's just an incredible person.
These are two wonderful people, and both of them have been great friends of the Huntsman School Business. Both of them have been great contributors of ours, and I think it's a great example of what people can do, when they're thinking about service as opposed to, something else. Because this is really a service that they're providing.
Well, it is, and the amount of time that these busy people like Kim Gardner and Scott Parker and Spence Eccles spend voluntarily, no payment at all, but just because they want to do the right thing for the community and help Intermountain be better. That has been such an inspiration to me, and I think it's an inspiration to our Intermountain colleagues, caregivers around the whole system, to know that these remarkable people, respected in the community, serve without payment, without any personal reward, except knowing that they help keep us on track by setting our goals and helping us move forward in Intermountain Healthcare. That's a profound example of selfless service.
Yeah. Okay, back to the audience. Oh, we have a question right down here in the front.
Before I ask the question, are you related to Mr. Sorenson of biotechnology?
No, James Lavoie Sorenson, I knew Mr. Sorenson really very well, and he's a generous donor to our Intermountain Medical Center. Our heart center there is named after Jim Sorenson, but not related. Same spelling of the name.
Okay, I did my MBA from Utah State in 2008. And my PhD in chemistry in 1971.
Oh,
There
good.
was a gap of 37 years. My question is, when I was in MBA, everything was on auto industry, and I asked my professor that, what about the healthcare? She said it would come as soon as you see it picks up. My question is, I'm on Medicare, and I have AARP supplement, and I'm very happy, no copayment, no nothing. But sometimes it makes me nervous when I see on internet that present administration is thinking of removing that guaranteed Medicare help. Instead, we'll have to go and market in the free market. Makes me nervous. So it's reasonable to be nervous because I don't know why I would be shopping around and whether I would be better off or worse off.
Yeah. So great question. Put me on the spot here. So the Republican health plan that has just been recently introduced to replace Obamacare has some pretty far-sweeping implications in changing the number of beneficiaries for Medicaid. That's probably the biggest one. The current estimate is that if the Republican plan passes, there'll be 14 million fewer beneficiaries of Medicaid in the United States next year. Medicare, there has been some talk about just giving people a voucher and saying, okay, here's your voucher. You go out and find insurance through a commercial payer for Medicare, which really that puts, that way the federal government can just say, we're going to just give a fixed amount, and we'll put the risk on Medicare beneficiaries to be able to find an insurance program for that amount of money that meets their needs. I personally think it's unlikely that Congress would pass such a thing. I mean, it's a possibility, but I think it's unlikely. We're going to have people rise up and say that's not fair to change things for people. There is a cost problem in Medicare. There's no doubt about it. But the solution to that cost problem, I don't think, is putting more responsibility on the Medicare beneficiaries. The solution to the cost problem is changing the incentives to get health systems and doctors to stop doing stuff that adds only cost or risk. that's where the big opportunity for reducing costs and getting better outcomes.
It's a great way to end this conversation. I wish we could go on another hour, but we actually have a Nobel Prize winner in economics
Yeah, I'm not
coming in.
intimidated, appreciate Nobel laureate.
So won't you join me in thanking Dr. Peterson, or Dr. Sorensen for coming today?
Thank you very much.